time because it was easier to park tonight, right? It's great. Yeah, okay. I'm very glad to be here again. My name is Ingrid Reed, and I'm a member of the lecture committee on the Princeton Adult School Board. And I think you've probably heard before, the lecture committee thinks up themes, and then we ask people to come and speak on the theme. Well, tonight I would just like to pay tribute to Cy Marchand, who thought up the theme and basically single-handedly invited our speakers to be here in this sequence of lectures that you're hearing. And so I don't know if Cy is here, but thank you to one individual on the committee that took the initiative. It's really nice. And we all take that. I'm really glad to introduce Catherine Taylor, a resident of our Princeton community for 16 years, and who is co-chair of our hospital, that is the Princeton Healthcare System Biomedical Ethics Committee since 2008. And she has actively participated in the ethics consultations at the hospital in overseeing intensive care unit rounds with students and residents, and staff education and policy formation, all as a volunteer. But you can guess that she also has a distinguished professional career in bioethics. She started out as a lawyer and then went on to get a degree in philosophy. And that led to obviously having an area of focus. And as an attorney, she worked on a number of legal issues in her career in Washington, D.C., involving cases before the Food and Drug Administration and healthcare financing, with a special emphasis on issues related to cancer and healthcare financing. In 2007, she joined the University of Pennsylvania's Center for Bioethics, working with both law students and medical students, as well as mid-career professionals. And she taught courses such as ethics in reproduction and ethics in the pharmaceutical industry. In 2007, she joined Drexel University. And you may not know that Drexel University has a College of Nursing and Health Professionals. I think only engineers go there. And there she teaches healthcare ethics to undergraduates and practicing nurses. You won't be surprised if I tell you that she has a long list of presentations, articles, media appearances, peer review assignments, and memberships, all in various areas that relate to bioethics. And we're delighted to have her here tonight as part of this series. Thank you, Catherine.
Thank you, Ingrid, for that kind introduction. And I'm delighted to be here today to speak in this interesting series of talks. I've been able to come to one or two of them, and I think it's a very interesting group of speakers. In thinking about what I was going to speak on today in this subject of bioethics, of course, it's a quite broad topic. And I was thinking about, well, should I speak about genetic technologies, ethics in reproduction, genetic testing, so many issues. But what brought all these issues together had to do with ethics of the use of technologies, whether it be an older technology or a new medical advancement. And they all involve the issue of how we incorporate technologies into medical practice and into our society in an ethical way. What uses of a technology are ethical and what uses are not? And how do we answer these questions? From ethical concerns about fetal surgery to genetic enhancement technologies, we're constantly challenged to decide what our values are in medicine and what technologies to incorporate. So I decided to address a broader theme of use of medical technologies. And I'll explore what some call the technological imperative in its many facets. In the second part of my talk, I want to focus more on the clinical setting, which is where I do a lot of my clinical ethics work, and talk about how technology in the hospital and even in physicians' offices can adversely impact the compassionate care of patients. Let's see, how do I do this? The history of bioethics itself can really be tracked by looking at various presidential commissions, advisory committees that are addressing technologies that have been developed, medical technologies. From 1968, when there was an advisory committee at Harvard that discussed how we should define death, since we were able to keep bodies alive, even though the brain was no longer alive, and they came up with the neurological criteria of death or brain death. Is it ethical to withdraw life-sustaining medical treatment? In the early 80s, there was a presidential commission that looked at the issues of withholding, withdrawing of life-sustaining treatment. All these issues arose because of the technology that we had developed, but it became a problem, an ethical conundrum as to once you start some of these treatments, when could you stop? Was it ethical to take someone off a ventilator after they'd already been put on the ventilator? So there was a presidential commission that looked at some of these ethical issues at end of life. There have been presidential commissions for the last 3 presidents, which discussed issues such as ethics and genetics. What are the ethical parameters of cloning, gene sequencing, of offering genetic tests for diseases that have no treatment? Would you want to be tested for Alzheimer's if there is no cure for it? Harold Shapiro, Dr. Shapiro, chaired Clinton's Bioethics Commission, and it's my understanding that he's going to be speaking to you about ethics and genetics, so I'm not going to be covering that topic thoroughly. There are also questions about reproductive technologies. Is it ethical to clone human beings for reproductive purposes? What should our view be of commercial surrogacy? In India, there is a cottage industry of surrogates who have children, and from the embryos that have been brought over there, and then after they've had the baby, the adoptive parents come and take the baby. Is this an ethical use of IVF? So there are many different complex ethical questions that surround our use of technologies. But there's one thing that's always certain, and that's the primary characteristic of the practice of medicine is the use of medical technology, or some would say the overuse of technology. Stanley Reiser, who's a physician, historian, and ethicist at George Washington, he's written a lot on this topic, and he says that the history of medicine, I can't see the top of my slide, the landscape of modern medicine is filled with machines. And this is true. You walk into the hospital, you'll walk past the cancer center with a lot of fancy medical equipment. We've got imaging equipment, we've got surgical equipment, we have pharmaceuticals, powerful pharmaceuticals, we have medical devices in our medical offices. It's almost as if the practice of medicine were the use of technology. And this is partly because there's a gigantic, huge market for medical technology and a big industry to fill that market. The industry's motto could be, if we build it, they will come, the line from Field of Dreams. And they do build it, and hospitals advertise the newest, shiniest machinery to attract patients, even when that machinery is not necessarily proved more efficacious and may be much costlier than the usual way of doing things. The entire healthcare industry profits, but costs rise. Here's an example of this. I'm not able to see my writing on here, so I'll have to look over here. I can't. Yeah. So this is the TrueBeam linear accelerator. With pinpoint accuracy, the all-digital TrueBeam linear accelerator delivers cancer-killing radiation, an important addition to the cancer-fighting arsenal The state-of-the-art equipment dramatically increases the center's range of radiation therapy. This is an ad taken from a hospital, but many hospitals advertise the new and shiny equipment that they've acquired that improves medical practice. Notice the battle metaphor, arsenal, medical technology, and also the emphasis on state-of-the-art. We love our new technology. Here's another thing I'm sure you've seen advertised on Route 1 and in the New York Times and elsewhere. This is the Da Vinci and SITM surgical systems, sophisticated robotic platforms designed to enable complex surgery. If it's complex, if it's state-of-the-art, it must be better. But there's a question. Wait, I got the wrong slide up here. About the efficacy of these technologies. And are the outcomes really better? This is an article that was in Healthline News about the Da Vinci robotic surgery system. It states, this is a technology that is costing the healthcare system hundreds of millions of dollars and has been marketed as a miracle, and it's not. It's a fancier way of doing what we've always been able to do. I was very lucky that this cartoon showed up in the New York Times last week in the New Yorker. See the man in the dental chair being approached by this gigantic, scary machine. But this illustrates a theme, actually. Technology can be scary. It can feel overpowering, unstoppable force that we can't control. Daniel Callahan, who's one of the co-founders of the Hastings Center of Ethics, has written a book entitled Taming the Beloved Beast. He observes that technology saves and improves our lives with its undoubted power to diagnose and treat. But in its unrestrained lumbering about in the house of medicine, increasingly wreaks financial havoc. So I would observe that technology can also wreak ethical havoc. Are we driving the technology, or is the technology driving us? I'm not a Luddite. I don't object to technology as a thing. The question is our relationship with the technology and whether we decide to use that technology for good or for bad. So there's developed what's called what some have called a technological imperative in our culture and also in the practice of medicine. Victor Fuchs, who is a healthcare economist, had first coined this phrase, I believe. It says physicians are imprinted that the best possible care involves the newest and most technological care. We have a larger cultural infatuation with technology in general, not just in our medical practice. As the mother of 3 daughters, I can tell you that many of my disputes with my children involve technology, when they can use it, when they cannot. Laptops, computers, iPods, apps, everything. It surrounds us. It's an obvious statement, but I think sometimes we don't think about it. We just kind of think, well, this is the way things are. Barbara Koenig, who's a medical anthropologist at UCSF, has written quite a bit on the issue of technological imperative. As a culture, we are fascinated with the details of medicine's most miraculous advances. The limits of technology seem boundless. The mere existence of a dramatic new device provides a mandate for its continued use. Eric Cassell, who is a physician, ethicist, has written a classic article called The Sorcerer's Broom, Medicine's Rampant Technology, where he talks about the technology used in medicine. Everyone loves the new and shiny, especially when it does fascinating or seemingly inexplicable things that enthrall us. Wonder and wonderment cause physicians to use and overuse their technology. They like to see it in action, and they want a new model as soon as possible. So what are the reasons for the technological imperative? What are the drivers? First, we have market forces, obviously, we discussed. Industry creates a market. The newer, the better. Hospitals purchase and advertise the equipment, and the equipment becomes the standard of care, a very expensive standard of care in medical practice. Patients also want it because they are led to believe that technological care is better care. Physicians want it, and we'll talk about this a little more later, because they believe it provides a certainty in diagnosis. It also enables them to do a lot of testing that they wouldn't normally be able to do, which they believe then protects them from malpractice liability. And we also have a medical culture of rescue. Daniel Callahan has said, death is just one more disease to be cured. All these together then create an atmosphere where technology and medicine becomes the norm, the standard. Medicine itself becomes the use of technology for various diagnostic and treatment-related purposes. What are some of the problems of our use or overuse of medical technology? 2012 Kaiser Family Foundation report has said that medical technology constitutes about 1/2 or more of the real long-term spending growth of healthcare. We have an aging population. The baby boomers are aging. Life expectancy is lengthening. So the Dartmouth Atlas report shows that the number of Americans aged 65 and older is expected to nearly double over the next 4 decades. Over the same period, the number of people age 85 and older is projected to nearly quadruple. So the cost of the use of technologies in all their forms is really unsustainable. The wonder and wonderment of the technology is we're not going to be able to continue our current levels of use. I don't really want to focus on cost because I know that there's going to be another speaker or more speakers that are going to talk about healthcare reform and healthcare costs. I'd rather focus on larger and more complex ethical concerns that arise with the use of certain medical technologies, such as gene therapy, reproductive technologies, and the like. So bioethicists, when they're helping to look at the ethical use of technologies, might ask, is the use of the technology ethical or unethical? Why? What harms can result from widespread use of the technology? What are the ramifications for public policy? So for instance, in the issue of cloning human beings, there's been a widespread consensus that cloning is not ethical, primarily because of the safety issues involved at this point. But also, cloning presents larger issues of what does it mean to be a person? What person should have access to this technology? Anyone who wants to be cloned? Only those people with serious illnesses, or not illnesses, but only those that are infertile? Should it be available to others that aren't married, that type of thing? Should it be available to gay couples, to lesbian couples? These are questions that we ask about all reproductive technologies, actually, but these are just some of the larger questions that bioethicists look at when they're analyzing the ethics of a particular technology. And one way you might explore the question is to ask, what are the goals of medicine, and is the technology consistent with those goals? What are some of the candidates for the goals of medicine? Are they to alleviate suffering? Or is it to alleviate suffering caused by a disease or malady Those are two candidates. And if the latter, how do you find disease? So I want to look at one example of this. It's called body integrity identity disorder. This involves the old technology of surgery, but the question is, to what use should surgery be put? So there is a group of people who now they've come up, the psychologists say that these people suffer from body integrity identity disorder, and they are persons who feel like they're not themselves, that they can't reach their true identity unless they become an amputee. So they want to get an elective amputation. Carl Elliott, a bioethicist, has written a book called Better Than Well, American Medicine Meets the American Dream, and he devotes a chapter to this issue, and it's absolutely fascinating reading, but also a little disturbing. When I was looking into this, I saw a website entitled Stump for Life, Serious Help for Them That Want to Become an Amputee. And they were helping people who want an amputation to match up with surgeons who will do this operation, and they charge anywhere from like $5,000 to $20,000, mainly in the Eastern European area. In May 2002, there was an article in The Guardian that argued that these types of amputations should be ethically supportable because the disorder could have neurological roots, could be biological reasons to have this psychological disorder as it's now been defined. And also persons tend to pursue self-amputation. So this is something that's being discussed. What is an ethical use of surgery? Not a fancy technology, but still something that we need to question as a culture. So what may bother us about this type of surgery? Is it because we're using surgery for elective purposes? Clearly, we do that already. Cosmetic surgery is a booming industry in this country, billions of dollars. No disorder attached. If you want cosmetic surgery, you can find someone to do it. So in that case, the market forces have taken over. Some in ethics argue that cosmetic surgery is not an ethical use of the technology of surgery. Is the surgery to treat a disease? I mean, here we have defined a psychological disease, body identity integrity disorder, that's being treated by a surgical means. Is that what bothers us? These are questions we have to tease out when we try to assess the ethical use of technologies. An issue that arises when we look at the use of technologies is the issue of medicalization and the markets that are created by medicalization. The wannabes, the persons who want amputations, are suffering from a relatively newly defined psychological disorder, and this expands the surgical market. I don't believe there's a big market in the United States, but there's certainly one in Europe. There was a physician in the UK who did this surgery a few years back, and he was roundly criticized for doing so, but there are surgeons who do this. So what used to be thought of as a normal problem becomes a diagnosable disorder, oftentimes because there's a technology there to address it. For instance, the use of pharmaceuticals for children. We have created the disorder of ADHD. Now we are marketing the use of Adderall and many other drugs for children. And many experts believe that the market for the drug far exceeds the number of children who actually have this disorder. Autism has been arguably overdiagnosed according to some experts. I can't read mine. Sorry. Bipolar disorder in children has become much more commonly diagnosed. And it's been quite controversial because one of the physicians who was instrumental in diagnosing this illness and speaking about it also had a relationship with a pharmaceutical company who sold a drug that treats bipolar disorder in children. So we're creating markets and we're medicalizing things that that weren't medicalized in the past. They weren't seen as illnesses, sicknesses. What about the issue? I'm just raising some issues. I don't have all the answers to these complicated questions. What about the issue of enhancing or improving the human condition when there is no disease? Creating designer babies, choosing traits for your children. We don't have any laws regarding this. It's something that we're debating in the bioethics community. Some actually argue that if the technology's there, we should be required to use it to improve the human condition. That is a minority view, but these are questions that you need to think about. Well, what are the societal impacts if we pursue this technology on a widespread basis? How would it affect our expectations for children who have been designed? Is it too much pressure on them? The parents have expectations they're going to be a certain way. They don't necessarily, it's genetic reductionism. We think that if we design them, they'll be exactly as we thought they would, but that's not how actually things work. What about fairness and access to technologies that could improve intelligence? Other very highly desired skills in the work environment. We're not able to do this kind of genetic enhancing yet, and for some traits we probably will never be able to, but we're already getting into this area when we talk about sex selection and pre-implantation genetic diagnosis. Should fertility clinics allow couples to choose the sex of their child? Should deaf parents, for example, be able to choose a deaf embryo to implant in the mother and purposely have a deaf child? So these are the interesting and complicated ethical questions that are asked about the use of the technologies that are being developed and obviously used, and they're also all very expensive. What about the issue of extending life? Again, as Callahan said, death is just one more disease to be cured. He's not actually arguing that's the case, but he's saying that that's how we tend to view it. Death has become the enemy, the failure of medicine, the last obstacle to conquer. Here is a company called Calico that's based in California that is working on stopping the aging process. We're testing aging, we're tackling aging, one of life's greatest mysteries. Calico is a research and development company whose mission is to harness advanced technologies to increase our understanding of the biology that controls lifespan. We will use that knowledge to devise interventions that enable people to lead longer and healthier lives. Executing on this mission will require an unprecedented level of interdisciplinary effort and a long-term focus for which funding is already in place. This company has been around for a while. It was one of the co-founders was one of the co-founders of Genentech. They have a lot of money, and this is the research that's ongoing. I'm not arguing that we shouldn't pursue any or all of these technologies, but the issue is, what are the ethical parameters of that? How do we want to use it as a culture? Is the horse out of the barn and there's nothing we can do to address this? Or should we, as a society, think about the ethical uses of these technologies? Some technologies we may oppose, some we may find to be perfectly acceptable. I want to move the discussion away from the larger questions of ethical use of technology in general on a policy level and take it down to the level of the patient and the healthcare provider. In my own work in clinical ethics, I spend lots of time doing ethics of patient care at the hospital. And the widespread use of medical technology in the hospital and the clinic greatly affects the care that is given patients, and not always for the best. We tend to think that the more technology, the better, but the overuse of medical technology can in fact contribute to less than compassionate patient care. These concerns affect all of us because we're all patients. This is a patient in an ICU. We've got the respirator, the heart monitors, other equipment. I'm not a physician, I can't even identify all of it, or a nurse, I'm not, but there's a lot of equipment in there. It's a typical ICU room. We tend to take for granted that this is the way an ICU should look. If there's technology there, then obviously they're doing what they should be doing. But all this technology and use of technology and overuse of technology can create what Stanley Reiser, who I mentioned before, has called therapeutic distancing. In modern medicine, he says, we often treat disease fully and the patient partially. We have equipment to monitor the heart, to monitor respiration, to monitor everything that could possibly be monitored. But the patient as person disappears. The patient is seen as a collection of organ systems which are diagnosed, they're tested, diagnosed by separate specialists. As a patient in the hospital may have a pulmonologist, an infectious disease doc, many other types of specialists, including, and the hospitalists on top of that. And all of these specialists become geographers of the body. They focus on one part, the functioning of that part. And the patient then becomes a vessel for disease, a collection of organ systems that each specialist is diagnosing and treating. But we tend to forget then the entire patient and the suffering of that individual patient. The patient, in fact, in some ways becomes invisible. That is not conducive to compassionate care. Think about an office visit when you go see your doctor. There's a parade of instruments. You come in, first you get your blood pressure checked, you have your heart listened to, you might have your ears checked, your nose checked. You might get an EKG if you're getting a physical. Sometimes you might get a quick physical exam, but primarily the physician's relying on instruments to perform diagnosis. There's a story of, not a story, just kind of something I heard someone repeat once, where there was a physician who was listening to the patient's heart, and the patient started talking. The physician said, "Be quiet, I can't hear you." Needed to hear the heart, needed to hear the heartbeat. The patient's reports of their disease, patient's story, not necessary to the diagnosis. Studies show that most physicians also interrupt patients within about 20 seconds of the patient beginning to speak in an office visit, because we are mainly relying on technology to do diagnosis, not the patient's report, their disease, or the patient's story. Even the fact that physicians are on the computer, are now putting their notes in a computer, can really contribute to therapeutic distance. I went to a neurologist to check out some pain I was having, and he was on his computer. Every once in a while, he would look up a beat, but mainly he was inputting my reports. I felt as if I wasn't really being heard. It really created a distance between us. But good communication is really necessary to quality patient care. And you can't serve the overall good of people if you don't know the patient's story. In fact, there's a whole field being developed in medicine and in bioethics called narrative medicine, which argues that diagnosis depends on listening to the patient, listening to the patient's story. Let the patient tell their story. The saying goes, the patient will tell you what's wrong if you will just listen. You don't need fancy technology to do that, but the technology interferes with that relationship. Why does this type of technology have such a hold on physicians? I'm not saying that this technology can't be useful. The issue is overuse to the exclusion of other ways of taking care of people. Cassell, the bioethicist I told you about earlier, has come up with a few reasons. One he calls the lure of the immediate. This is all the readouts, imaging results are very quickly obtained, and they reduce the sick patient to something much more simple, data. In the ICU, for example, the lure of the immediate often means that dealing with immediate test results instead of doing long-term care planning. The short-term goals of addressing patients' needs the long-term goals are ignored because you're doing this short-term goal of getting all the data you can. It gets in the way of providing empathetic, compassionate care. Cassell says, God bless the immediate. No need to get caught up in all that complex sick person stuff. That's why, given a complicated human question in the care of the sick, we doctors love to start talking about physiological parameters, calling up diseases, or planning some tests. That's then the immediate go-to position, is to do some tests. They also love the technologies because of the lure of the lure of the unambiguous, Test results, lab readouts, imaging are simple, clear, and usually unambiguous. But what happens, I'm place here, is that oftentimes then these unambiguous test results are used to overdiagnose certain conditions. For instance, we use a spirometer to test for asthma. Well, the studies have shown that asthma is overdiagnosed, possibly even by a third, because of the testing we use. Instead of just using one test, instead the entire patient's history should be looked at rather than one unambiguous test result. Another reason why technology has a hold on physicians is the pursuit of certainty. Of course, we all want certainty, physicians and patients. Cassell says the central problem that physicians confront is uncertainty. It is doubt that grays hairs. We rely on technology to reduce diagnostic uncertainty and shrink the clinical problem until it's a problem not of the patient, but of an organ system or a number of organ systems. Overuse of the diagnostic technologies is common because physicians have become quite uncomfortable with uncertainty. Now, often the argument comes up, well, physicians have to perform tests, and more tests because of the fear of lawsuits, defensive medicine. That's a valid fear, but it's the physicians, healthcare providers, who develop the standard of care for treating disease. They have the expertise. And patients are infatuated with technology because they see it as better. But it is the providers who are the intermediaries of this technology. And I believe that it's not just fear of malpractice. I think that they're drawn to the technology for several of the reasons that Cassell has stated. Another issue with the use of technology in the hospital or in the clinic is the ideology of rescue. Therapeutic distancing is one way that technology interferes with compassionate care, but another is the neglect of terminally ill and dying patients who can no longer be rescued. I know that David Borelli will be speaking to you in one of these sessions about improving end-of-life care, but I want to focus on how this ideology of rescue contributes to that problem. Helen Stanton Chappell, who is a nurse ethicist and anthropologist, went out and did field work at several different hospitals, and she's written a book called No Place for Dying, Hospitals and the Ideology of Rescue. And really, her thesis, and I'm sure none of us are surprised by this, is that hospitals are places that we rescue persons with acute illnesses, persons that can't be cured. Care is centered around the more expensive task of rescuing patients with surgery and technologically expensive machinery. So death or terminal illness becomes anathema to rescue. So neither hospitals nor nurses or others are adequately equipped to deal with death because rescue is the mission. So the care for the dying becomes a low priority. Chappell observes a troubling phenomenon, for instance, where dying patients or those with no codes, this was in a 340-bed Catholic hospital that she was observing, were shuttled to another floor to preserve the more expensive code beds. The telemetry nurse on the floor where the patients were shuttled to gives a statement. They're sent from the ICU. They send them automatically to us. When the ERs happen, they'll send them as soon as they extubate. Sometimes they die in 5 minutes. They don't want them to die in the ER. They send them to this other unit to die. Sometimes it can be a little stressful. The ICU is famous for sending us patients. We have 4 hospice beds, and the telemetry unit is famous for it. This patient had been made a no code, and they call and ask, can we send him to your floor? This is supposed to be a place that's good at it, but it's like we're a dumping ground. When they're actively dying, they'll send them to us, and they'll die in transport. We haven't valued as a clinical specialty, as a valid clinical goal, assistance in dying. And I'm not talking about physician-assisted suicide, I'm talking about creating atmosphere of a peaceful death, if at all possible, in a hospital. We don't value that as a specialty. And in the hospitals, it becomes almost an impossible thing to have a good death. They're organized around the ideology of rescue and the maximizing technological use. Because they're organized around the ideology of rescue, many critically ill patients end up in the ICU at the end of their lives. This has become a big problem, especially in this state. The Dartmouth Atlas reports that the average number of days spent in the intensive care unit in the last 6 months of life is actually trending upward. And New Jersey is a state with one of the highest rates of utilization of the ICU near the end of life. And this is true even though studies repeatedly show that patients and their families don't want this kind of care. We do advanced care planning, we may execute living wills, we do our best to prevent aggressive care at the end of life. But the system of the hospital puts us through to the ICU often before anyone can even raise the issue. And so many elderly patients or terminally ill patients end up in the ICU toward the end of their life. Once they're in the ICU and if they're close to death, what happens then is their death is prolonged. Their dying process is prolonged. We go from rescue to allowing death. We need to go from rescuing the patient and preventing death at all costs to allowing death of the patients and treating that death as something that's worthy of clinical care and attention. So much of our ethics work at the hospital is focused on ethical concerns around whether a patient's dying is being prolonged by technology. On daily ICU rounds, providers report lab values, readouts, MRI results, stability of various organ systems. And one of the most useful questions as clinical ethicists that we ask on the ICU is, tell me about this patient. What is her story? Where is her family? What did the patient want at the end of life? The focus needs to be turned from short-term goal of continued rescue of the patient to what is in the patient's best interest long-term. Perhaps a peaceful death is the better choice in many situations. I want to close with a final thought. Medical technology gives the healthcare industry and physicians and nurses and others the incredible power to heal, but also the power to inflict suffering on patients by its overuse. As stewards of that technology, it's incumbent on healthcare providers and healthcare institutions to use the power wisely for the benefit of patients and not simply because it's there to be used. And one of the primary roles of bioethics has been to help us think about how to use that technological power as a tool for good, and also to inject a dose of humility and remind us that even the power of medical technology has its limits. Atul Gawande, at the end of his book, Being Mortal, says that being mortal is about the struggle to cope with the constraints of our biology, with the limits set by genes and cells and flesh and bone. Medical science has given us remarkable power to push against these limits. But again and again, I've seen the damage we in medicine do when we fail to acknowledge that such power is finite and always will be. Thank you for your attention, and I certainly available for any questions you might have. Sure, I can send a PowerPoint to Kim, who's one of the coordinators.
And if you could repeat any of the questions they're asking.
Oh, she wanted a copy of the presentation. Yes. Oh.
How does the discussion go at the hospital when there are kind of questions that you brought up now? Who gets to decide, or is it consensus? What is that process? Can you talk a little bit about who gets together and how do you go about deciding?
Right. That's a good question. At the hospital, there is a very active biomedical ethics committee, and there's a subcommittee that does clinical ethics consultation. So anyone involved in the patient's care, whether it be a family member, the patient themselves, a nurse, a physician, can ask for an ethics consult. This is to empower persons besides just physicians to call ethics consults. It used to be that only physicians could call them, but many nurses would be in moral distress about the treatment of certain patients and didn't have the power to do that. So at the hospital here, anyone can call an ethics consult. And then the ethics consultants, at least two, will go in and talk to the person who called the consult, they'll talk to the physician, to the nurses, to the patient, to the family, as many people as they can speak to, given time constraints and that type of thing. And then give ethical guidance if there are clear parameters that are obvious, such as, does this person have an advance directive? If not, what do you think this person would have wanted? Say it's someone in the ICU and there are disagreements about whether care should be continued or not. What would the patient want? I mean, these are the established ethical parameters of this kind of case. It's not up to the healthcare providers. It's up to the patient, what they would want. If we don't know that, it's up to the family. At the same time, families can't demand care that's inappropriate, that has no chance of succeeding, just for the purposes of care. So there's a balance there that needs to be struck between the different persons. Usually what happens is that we just sit around and come to a consensus in a meeting with the family and others. So it's not from up high, it's a participatory democracy at the hospital. Yes?
I've spoken with several doctors, and they are aware of the situation where they don't have sufficient time to have the conversation with their patients because of what they call billable hours. They have to meet a number of patients in a day in order for whatever practice to meet their particular compensation. So while they are speaking with a patient, they are also having to type in the response of the communications they're having with the patients. And they're multitasking by asking questions, looking at the readouts, typing it in, and before you know it, they'll ask you then, do you have any questions? And you kind of anticipate, you'd like to know from the doctor what your particular situation is, and you sense you only have about 3 or 4 minutes because he needs to get on to the next patient. So how do they internalize the problem they know that has been created?
That's a very good question, and doctors are really under a lot of pressure and stress to, especially in office visits, to take as little time as possible because they are supposed to treat a certain number of patients in a day, depending on their practice scenario. I mean, some are not under those pressures, others are. One incentive that's been devised is that Medicare is now going to reimburse doctors for having end-of-life conversations with their patients. I think in some ways it's unfortunate that unless there's money involved, the physicians feel they don't have an incentive to do this. Because it really is the physicians who have the obligation to raise these issues with their patients and listen to their patients and listen to their patients' stories. One of the main problems is that we don't teach these types of skills in medical school. Physicians also, as many as, even though they are physicians, often don't feel comfortable addressing issues of death and dying with their patients. Even physicians who treat critically ill patients in the hospital. It's something that needs to be addressed in training, in modeling. It's a real issue. Yes?
How do you keep hospice from becoming just another billable service where the quality is?
How do you keep the
Hospice from
Hospice?
becoming just another billable service instead of a quality end of life?
Well, first we need to encourage more use of hospice. You said hospice.
Hospice, yes. I
Most people are not referred to hospice until far too late. And so I think while hospice does need to make money, we are underutilizing hospice right now. Many people are not on hospice till the last 2 weeks of their life, because we see hospice as something that means you're giving up, your life is over. But in fact, some outcomes data shows that patients who go on hospice often live longer than those who don't, because their needs are addressed, their suffering is addressed, they're maybe more comfortable, they're less stressed. So hospice can be a real service. I understand your concerns that hospice could just become a
I have a
business.
friend whose wife went into hospice, and it was this woman who came in to put in her hours. She did not get hospice services.
Right, well, that's unfortunate. That wasn't a good hospice service. Yes.
You say it's sort of the responsibility of the physician to examine whether overtreatment or a lot of diagnostic treatment is there. But as we are an aging population, are you finding that more patients are actually taking that responsibility to have those conversations with their families, with their doctors as a separate thing, not necessarily as billable, filling out something like the 5 wishes or something?
Right.
Has that increased?
Oh, definitely, and I think it is. It's not just the physician's responsibility to bring it up, but ultimately it's the physician who has the obligation, the ethical obligation to the patient to act in the patient's good. However, that has certainly become much more common now. People are doing a lot more reading about end-of-life care planning. They're executing advanced directives. They're talking to their families, and that needs to be encouraged more. But one thing that I think people forget is that even if that hasn't been, even if you've never executed a living will, I always tell the healthcare providers to the patient still has capacity to think, make decisions, ask them what they want before they use it. And then it's in the medical record. That's just as valuable as an advanced directive. Oftentimes, advanced directives are too general and they don't specifically address the situation that's being.
But also it's the conversation with the family and the people who may be your advocates at the hospital or at the end of life.
Right. I mean, we need to have these conversations sooner. What happens is that the patient goes downhill over time and people don't want to bring it up. But I think it's the nurses, physicians, the institution's obligation to try to start these conversations that the family themselves haven't started the conversation, even though they can be quite difficult conversations to have.
Last question.
Do you think that there is a role that healthcare providers have in promoting this whole rescue, super technology, mystical powers of hospitals? You just have to watch primetime television for an hour and see healthcare, major medical centers advertising their success rates for curing bizarre diseases that maybe are cured 1 in 100 times, and yet they brag and they promote and they tell you that they are miracle workers. So why are patients' expectations then unreasonable, and then you have to undo all of that when they're confronted with reality in the hospital? Aren't healthcare providers responsible for the unreasonable expectations that their patients have when they're
You mean hospitals?
Yes, hospitals,
Institutions?
healthcare providers, pharmaceutical companies. All of these people that
Absolutely,
are part of this mechanism, why don't they stop doing it?
because it's a market. Even if they're a not-for-profit institution, they're still competing for patients, and because we love our technology so much, it becomes a cycle. But it is misleading, I agree with
Well,
you.
we only love the technology because the doctors tell us to love it. They tell us they can help us live forever. And it's the physicians who are getting themselves, you talk about defensive medicine, well, even the lawyers for, defensive medicine, the doctors are responsible for creating unreasonable expectations in their patients. If doctors would be more realistic from the beginning, I think it would be a lot easier problem. You should be lecturing the doctors.
I'll do whatever I can.
You can always tell them you heard this lecture.
Yes.
Thank you very much, Catherine.
Thank you.